Thank you, Siddhartha. It was a pleasure to have me here, and I'm really honored that I'll be speaking this session as cataract surgery in patients with pre-existing uveitis. I have no financial interest, whatever I show. But the pre-operative evaluation and the complete evaluation is ophthalmic evaluation is what you need. Look for glaucoma, CME, retinal neovascularization, poor visualization. If you see the posterior segment, if you cannot see, obviously you need to do a OCT or a B-scan ultrasonography and a systemic examination and laboratory evaluation. Definitely need to do that. Indication for surgery in uveitis is post-uveitis is usually visually significant cataract, as would be in any other cases. Cataract precluding any posterior segment evaluation, that's also needed, and any phacoantigenic uveitis. So preoperative control is must. A quiescence period of 3 months is preferred. A multidisciplinary approach is to be done. Topical, systemic, corticosteroid, immunomodulator, whatever way, you just make the eye quiet. And look for adverse effects. Visual prognosis depends on basically presence of pre and post-surgical inflammation, quality and efficiency of surgery, and of course, management of complications. How to prepare for surgery? Steroid responders. I mean, you must have given steroid preoperatively to control the inflammation. So if you see that in pre-op steroid regime may be modified in this sort of cases, intravitreal triamcinolone, dexamethasone before or during surgery, you take a decision on based on whether CME is active or history, there is a heavy flare or high risk of flare-up. And IV methylprednisolone 1 gram again would depend on to replace the pre-op oral or post-op oral therapy. You can do that steroid regimen. Well, ECC versus SICS. Well, definitely there is increased incidence of clinically significant inflammation requiring treatment, and phacoemulsification remains the surgery of choice because of the decreased incidence of clinically significant inflammation, decreased CME and epiretinal membrane, decreased surgical time, minimal tissue handling. This is all known to us. Pars-plana vitrectomy may be required in cases where uveitis is associated with vitreous opacity, and these are the two studies which course there is definite improvement, 72.2 to 63.2%, and most the different cause of word vision is due to CME or glaucoma, secondary glaucoma. Intraocular lens, we know you should avoid ACIOL, sulcus fixation IOL, silicone IOLs, IOL with polypropylene haptics. Oil implantation is less than 2 years of age, well, it's something to be careful. Well, definite preference is PC IOL in the bag and acrylic IOLs heparin coated. Well, there are studies to suggest that even hydrophilic acrylic IOLs, but definitely acrylic IOLs are the IOLs of choices. This is the study by Ajoy, the acrylic IOL, there's definitely less inflammation. And then again, there is a hydrophobic plus hydrophilic IOL. The PCO seems to be more with the hydrophilic IOLs and definitely better EVL compatibility, the study says. So let's come to this small surgical clip. Well, this is a cataract, which is, you can see it's a dense cataract. At the same time, there's a fibrotic capsule. So what we are doing is trying to extend the pupillary area. See this two Uglan soup. This is the fibrosed. So I put in hooks there in this case, and the hooks definitely give me the enough size. Look at this, how fibrotic it is. It can be very difficult in this sort of cases. You have given steroid, you have given immunomodulators before surgery, maybe you have given intravitreal or just after the surgery, you can add intravitreal, either triamcinolone or see we are using scissors to cut that capsule. And sorry, this is gone there. And once this is there, see, I'm using scissors. Well, and then many times you have to be very careful that you don't pull on the zonules. Zonules can come off in this sort of cases. So be careful, do the emulsification. Normally they are softish cataract because this is a secondary cataract. It's not a senile type, but then emulsification is done. And then in this case, as we finish up the case, we are putting in a hydrophilic IOL. As you can see, this is a hydrophilic IOL. This patient did very well. This was done almost 7 or 8 years back, and I'm using hooks there, and the hooks are removed at the end of surgery. Most of the time, the hooks can end up in disfiguring your this pupillary margin. So that's why those pupillary expanders are come. This is another case where this, you can see this is also in a bad case, bad condition. See, so I'm trying to look for a area where I can puncture that area. I'm using forceps, and there I'm blunt dissecting, taking out that membrane out, taking that membrane out. See, there it is. I'm using scissors also at some point of time, and then once this is done, well, I a little bit of dilatation, manual dilatation. That's what I do, manual stretching, and then once that is done, I do prefer into using this case a BX. Our friend is there who has invented that, and this comes really handy in this case. As you can see, I put in the yes, CBX goes. I get a dilatation around 5.5 millimeter. Basically, you don't get much more than that. And then this is a soft cataract. I just go in and remove the cataract. And then in this case, I prefer to put in a hydrophobic IOL. Hydrophobic IOL, as I said, that they do acrylic hydrophobic IOL. Go and get the visco from behind and above the lens, try to remove as much to lower as much chance of inflammation, because this is inflammation prone, and then put visco in front of the lens and then remove the lens there and trying to remove that. And then at the end of the surgery, I'm just trying to get that back to shape using the IA here, and that's how that gives definitely a good result. And I put in it, as you can see at the end of the surgery. Here you can see at the end of the surgery what the inflammation is on here. That I put a intravitreal triamcinolone. So post-operative inflammation, pre-operative control. This will depend on how you control the inflammation pre-operative. Minimal or intraoperative tissue handling in the back placement of IOL, NSAIDs, and topical or periocular steroids as may be deemed necessary, and intravitreal triamcinolone. One have to be careful of the IOP rise also. So this is the different uveitis, and the folks in heterochromate iris shows better prognosis, 80% having more vision. GIAs can be very difficult patients because higher incidence of membrane formation. Behçet's disease also does good, so does toxoplasma. There might be recurrence. Eye implantation is not recommended in GIA. Basically, sarcoidosis, good visual outcome, multifocal choroidal. Also, it might chorioretinitis after within 6 months it might return. CME is very high, 21 to 50%. So lesser with well-controlled uveitis and oral corticosteroid, and a recurrent one can lead to permanent visual loss. And this is the study. CME, well, as I said, intravitreal triamcinolone can be tried. Fluocinolone I have not tried, but I have tried with dexamethasone. Definitely good result. PCO is also incidence is very high, 23 to 96%, and that will be pigment deposits. As I said, juvenile infective arthritis can be very bad. Inflammatory membranes forms, and they are very difficult to manage. So IL is not recommended in this patient because you get IL dislocation will also be reported because of the fibrosis that sets in later on. You can have posterior synechiae, chronic uveitis, IL envelopment, anterior capsular phimosis, shrinkage, and all. So these can be controlled by giving adequate amount of steroid right from the beginning. Lens cell proliferation, cytolytic membrane can lead to phthisis. So in conclusion, young patients typically at work or study, complex problem, high expectation, prolonged management course, but don't be hurried for the surgery. Waiting for and preparing for the correct time makes the difference between good and long-term result and blindness too. So control inflammation first, and definitely an experienced surgeon is better equipped to handle these cases than novice surgeons. So the take-home message is diagnostic evaluation of uveitis, pre-operative control, immunomodulator drugs, and careful surgery and selection of head forms the mainstay. And there's a few studies. This is a study from Shankar Netala, Dr. JB, and Dr. Virendra, which says the pre-operative and post-operative inflammation of modern-day surgical techniques are definitely better. The intraocular lens designs that are there. And this is another surgery decision making when you do so pre-operative corticosteroid prophylaxis, and in patients less than 2 years of age, the eye where inflammation is poorly controlled, intraocular lens should be deferred. This is the Dr. Chi, now their study from Singapore. And with proper patient selection, improved surgical technique, optimized pre and post-operative care, patient uveitis can have a good result. And this is again intravitreal dexamethasone implant study, which is a randomized trial, definitely has shown better result Then this is a study by Dr. Ajoy and team. And this is the guideline for immunosuppressive drugs in patients with ocular inflammation. This is a big guideline there. You can see the anti-metabolized T-cell inhibitors and alkylating agents for all everything. And just last, not the least, this is the AIOC study. Again, Dr. Chi, decision making. And so patient must be monitored closely. This is very important. Once you've done this surgery, don't forget about it. Let the patient come back and monitor it. Thank you. Thank you for your patient hearing.